Welcome to part two of our series, which is looking at patients with bleeding disorders. The learning objectives. On completion of this section, participants should be able to describe bleeding orders of concern, assess and manage such patients in the dental chair and refer if appropriate, and communicate with medical practitioners about patients with bleeding disorders. Why is it important for dentists to know about bleeding disorders? Well, dentists may be called on to treat patients who have bleeding disorders and also to manage patients who have excessive bleeding after extraction or surgery. Most people who have prolonged bleeding after extractions or surgery do not have a bleeding disorder and can be managed with local measures and do not normally require blood tests or referral. Whether a patient with a bleeding disorder experiences excessive bleeding during or after dental surgery depends largely on the type and severity of the bleeding disorder. A careful assessment and planning is necessary prior to surgical treatment of patients with bleeding disorders, and this may involve communicating with the patient's medical practitioner or hematologist. The medical history is very important and should contain questions on bleeding. Has there been any significant or prolonged bleeding after previous injury, surgery, or extraction? Do they have frequent nosebleeds or heavy menstrual periods? Is there any family history of bleeding? Or are they taking any medications which cause bleeding, for example, anticoagulants? Do they have liver disease or hypertension, which can also predispose to bleeding? In some cases, blood tests may be needed, and these can include bleeding time, APTT, PT, platelet count, or INR. We need to understand the normal hemostasis. After a blood vessel injury, there can be three mechanisms to help with hemostasis. Firstly, we have blood vessel constriction. We also have platelet activation and activation of the coagulation system. This results initially in a primary hemostatic plug, and after fibrin and thrombin are laid down, along with reduced blood flow, we get a stable hemostatic plug. There are four main types of bleeding disorders: coagulation factor deficiencies, platelet disorders, vascular disorders, and fibrinolytic defects. We're going to focus on the first two in this lecture. Coagulation factor deficiencies can be divided into two groups: hemophilia A and B and von Willebrand's disease are congenital disorders, whereas liver disease, vitamin K deficiency, and medications such as warfarin and aspirin are acquired. Hemophilia A is usually inherited, and it's an X-linked recessive condition affecting males, although females can be carriers. There may be a history of multiple bleeding incidents. Severe hemophiliacs may have bled into joints, limiting their mobility. Most people with severe hemophilia require regular supplementation with intravenous recombinant or plasma concentrate factor VIII. Some individuals with severe hemophilia and most of those with moderate and mild hemophilia are given factor VIII only as needed, without a regular prophylactic schedule. Mild hemophiliacs often manage their condition with desmopressin, a drug which releases stored factor VIII from blood vessel walls. It's important to note that about 15% of patients with hemophilia develop antibodies to factor VIII, and this makes their management more difficult. Hemophilia B, or factor IX deficiency, is also called Christmas disease. They bleed in a similar way to hemophilia A patients. However, their condition may be, in many cases, less severe. Von Willebrand's disease is the most common hereditary coagulation disorder. Both males and females are affected, and there's a wide range of severity from mild to severe. We get prolonged bleeding in these patients. Factor VIII activity is decreased, and platelets don't adhere to each other. Liver disease can be another cause of bleeding. In this case, synthesis of clotting factors is impaired. Sometimes bleeding can be controlled with vitamin K or fresh frozen plasma. For these patients, we may need to consider reducing the prescribed drug dosages. Common causes of liver disease are hepatitis C, hepatitis B, and alcoholism. The liver goes through a number of stages, from being healthy to having fatty liver to fibrosis of the liver, and finally cirrhosis of the liver. Platelet disorders are in two main types: quantitative, and here we're referring to thrombocytopenia, and qualitative, which are platelet function disorders. Thrombocytopenia is defined as having less than 150 times 10 to the 9 platelets per liter. And there are three types. Idiopathic, the main one being immune thrombocytopenic purpura, or ITP, which is an autoimmune condition, usually following a viral condition or viral illness. There's also thrombocytopenia caused by drugs, such as patients having chemotherapy or radiotherapy, or the drug valproic acid. And some blood disorders and malignancies, such as leukemia, can also cause thrombocytopenia. Qualitative conditions include congenital, such as von Willebrand's disease, and acquired, drug-induced liver disease and alcoholism. The minimum platelet blood level before oral surgery should be at least 50,000 per microliter. In severe cases, the patient may need a blood transfusion before invasive treatment. Blood disorders can present in a number of ways. It depends on the type of bleeding disorder. Sometimes we see frequent large bruises or ecchymosis. We can also see petechiae or purpura, bleeding under the skin or mucosa, causing tiny purple, red, or brown spots. There can also be redness, swelling, or stiffness and pain from bleeding into muscles or joints, which is particularly common with severe hemophilia. And bleeding nose is also a common feature. Orally, the presentation depends on the type and severity of the bleeding disorder and can include excessive or prolonged bleeding after extractions or surgery, spontaneous gingival bleeding, or petechiae, purpura, or ecchymosis in the mucosal tissues, such as shown here on the palate. Patients with bleeding disorders may first be diagnosed following oral bleeding. One study in the United States found that 14% of all hemophilia patients and 30% of cases with a mild type of hemophilia were diagnosed early following an episode of severe oral bleeding, of which the most common sites were the labial frenum and the tongue. So dentists are in a good position to identify some of these patients. Bleeding in the presence of gingival overgrowth may indicate an underlying hematological malignancy, such as leukemia. Patients with bleeding disorders do have oral health issues. The chronic bleeding of the gingiva may cause brown staining of the teeth. Patients may have more dental caries and periodontal disease and may lack effective oral hygiene and professional care. This can be due to a fear of causing oral bleeding, so they may neglect to avoid brushing their teeth or avoid going to the dentist because of a fear of oral bleeding that may occur. In addition, many dentists may be reluctant to see patients with bleeding problems. Management of bleeding disorders in the dental clinic will depend on the type and the severity of the bleeding disorder. For non-invasive dental care, this is normally safe. We often need to communicate with the patient's medical doctor and sometimes the hematologist. Use a minimally invasive approach to minimize trauma during surgery. If there's a severe bleeding disorder, endodontics is preferred over extraction. If the patient has a severe coagulopathy, transfusion of appropriate factors to 50 to 100% of normal levels is often required. And this must be continued post-operatively for some period. Of course, we must also use local hemostatic measures such as pressure, sutures, hemostatic foam, and a tranexamic acid mouthwash. We should avoid prescribing aspirin and other non-steroidal anti-inflammatory drugs to these patients. And there should be a strong emphasis on prevention and oral health education so that their treatment needs are minimal. Injections in patients with severe bleeding disorders is an area of concern. We should avoid mandibular blocks or lingual injections in patients with a severe coagulopathy, as there's a risk of hematoma or swelling in the retromolar or pterygoid space, leading to airway blockage. There's less danger if the clotting factor levels have been raised by appropriate replacement therapy. In these cases, we should use more infiltration and intraligamentary injections, and also use articaine. Local anesthetic that's used should contain vasoconstrictor. Here are some of the local hemostatic agents: gel foam or absorbent gelatin sponge material that can be put into sockets, for example, oxidized cellulose such as Surgicel, fibrin sealant such as Tisiel, topical thrombin, and tranexamic acid, which is an antifibrinolytic mouthwash, which supports clot formation. Tranexamic acid can come either as an injectable solution, which can be used as a mouth rinse, or as tablets. And if using tablets, crush the tablet up and mix it with about 10 mils of water or saline and use that to rinse. For the systemic management of patients with bleeding disorders, the hematologist has a number of options. Platelets can be transfused if patients have less than 10,000 per millimeter cubed. Fresh frozen plasma and cryoprecipitate may be given IV, and these contain coagulation factors. So this might be used in cases of severe liver disease or an undiagnosed bleeding disorder with active bleeding. Factor VIII concentrate can be given to patients with hemophilia A, either with active bleeding or pre-surgery, and also for some patients with von Willebrand's disease. Factor IX concentrate may be given in patients with hemophilia B, and in certain bleeding disorders, such as aplastic anemia and liver disease, aminocaproic acid can be given, which slows the breakdown of blood clots. Finally, for patients with von Willebrand's disease and mild hemophilia A, DDAVP may be given, which increases the amount of factor VIII and von Willebrand's factor circulating in the blood. For the dental management of bleeding disorders, if the disorder is mild and we're doing non-invasive procedures, there can be slight modifications or no modifications needed. If the bleeding disorder is severe and we're planning invasive procedures, the aim is to restore the hemostatic system to acceptable levels and maintain hemostasis by local and adjunctive methods. In these cases, we should consult the patient's doctor. For drug-induced coagulopathies, such as where the patient is taking warfarin or heparin, we should stop or modify the drugs prior to the appointment. With heparin, the drug may be stopped by the doctor. For warfarin, the dosage can be reduced. So in patients taking warfarin, before the appointment, we need to know the patient's INR. The normal INR in warfarinized patients is between 2 and 3. And dentists can carry out most minor surgical procedures, such as extractions, if the INR is less than 3.5. If the INR is more than 3.5, we should consult with the doctor and suggest that they can reduce the dose of warfarin and then later measure the INR again. Local measures to control bleeding should be put in place, including a tranexamic mouthwash for 2 days. In summary, bleeding disorders can impact on our treatment planning and management and may pose a serious risk to these patients. Communication with the patient's doctor is important, and most patients with mild to moderate coagulopathies and platelet disorders can be managed with local measures. Severe bleeding disorders may require platelet or factor transfusions, and these should be managed by a hematologist. prevention is very important in these patients. Here is some further reading if you're interested. Thanks for your attention.